I think when people choose to become physicians, they're driven by the need to make a difference. Where you truly, truly, truly leave a legacy behind of people who continue the service to humanity. But the deepest personal satisfaction comes with the patient interaction. That is what keeps you going back in there every day. That's what makes you feel. That's what makes you, in the middle of the night when you're doing a transplant and you think everything is falling apart, it keeps you together to deliver that care, to take that child back and hand it back to its parents. It's the ultimate act of trust when somebody gives you their child. It's not about the doctors, the nurses, or anybody else, or even CHOP. It's about the child.
What attracted me to the Children's Hospital was actually Dr. Downs and Dr. Bachman. And in particular, what I found appealing was the extension of the anesthesiologist's care beyond the operating room. In critical care, the opportunity to interact with all the disciplines in medicine was very appealing to me. We were breaking new ground in various ways of supporting and treating illnesses.
When I first became the head of the department, I was young, 30 years old, but this was the standard conventional wisdom of the time in an academic department. And that is that research was a very important part of being an academic physician, that you should look at the work that you were doing and try to find new knowledge about what you were doing. As our skills got better, as we did research and we learned how to breathe for patients and we learned how to support their circulation in the operating room, people began to get the idea, and that a lot of that originated right here, that we could take those same skills and take them into all parts of the hospital for all kinds of critically ill patients.
Critical care was an outgrowth of the knowledge and skills that an anesthesiologist should possess to take care of patients in an operating room. And we eventually were able to prevail on the administration and move a number of wards around to create a 6-bed pediatric ICU right outside the operating room in the old hospital. So that's the evolution of critical care.
I think it is a fair assessment to say the timing in getting anesthesiology and critical care medicine together as a collective discipline was very important, particularly in the early years. And so if you look at any ICU in the country, at least half the patients in there are post-operative patients. And the best person that has the best perspective on the recovery is an anesthesiologist who is in the OR, knows what's going on, sees the elements, and then can foster the post-operative care.
Michael came to Children's Hospital of Philadelphia on April the 24th in 1967.
Michael was obviously struggling. We had a chest x-ray from Reading that showed that he had a classic picture of respiratory distress syndrome. We knew he wouldn't survive unless we intervened and intubated his trachea and assisted him with mechanical ventilation, which we proceeded to do. And a picture was evolving, and he could not be liberated from the mechanical ventilator. And we told the parents we're out here in new territory.
In the beginning, it was a very, very stressful time. It was like up and down and up and down, and we'd be encouraged and then discouraged. He was hooked up to all kinds of tubes. That first trip home was very difficult, and I think I cried most of the way home.
I was receiving some criticism indirectly from some of the pediatricians that by doing what we did, instead of letting this baby's natural process evolve, which would have been death, we were creating a situation where we would have a baby who would probably be brain damaged and have permanent lung damage and probably have a miserable life if he did survive.
I think a large program like the Children's Hospital of Philadelphia with subspecialties in pediatric anesthesia and critical care medicine not only has the opportunity to identify the unanswered questions in the field, but really has an obligation to come up with the answers. I think there's a huge number of firsts that have been done here at CHOP and in all the subspecialties within the department, not only in clinical investigation, but translational investigation and even extending into basic science research.
Anesthesia was very attractive to me because you saw your results right away. You injected something and you saw something happen. And the intellectual stimulation of how these things work, even today, why anesthetics work, is still a great mystery.
It was a matter of having everybody develop the confidence that these things that we were doing wouldn't be harmful and leave a person handicapped or disabled, that in fact they would allow them to return to productive and normal lives.
I think one of the key things to think about in terms of anesthesia, critical care, pain management, and quality improvement is that we have become, to a large degree, the mortar that holds the bricks together in the hospital. And that much of what we think of as what's important in making the experience for patients better, improving quality, is being driven from the operating room and from people who do anesthesia, critical care, pain management.
I think there's a huge legacy here at CHOP of pioneers such as Jack Downs, Len Bachman, Russ Rafferty, who really moved the field forward. And I think that that's what is the driver to come to work every day, because you want to continuously learn and you want to continuously be able to do something that you weren't able to do 5 years ago. And I think that every decade we get better at what we can do.
In almost any important, serious endeavor, people have to always be improving, because if you stay still, you're going backwards. It's stunning that in many places the mortality rates used to be in 20+%. Now we're less, 1.5% to 2% of children that come into our intensive care unit do not survive. That is 98 to 99% survive their illness and move on. And we keep wanting to get better and better at that.
In life, everything is about luck. This was the right place at the right time. Things were changing. People were beginning to see anesthesia as a good career to go into. This was one of very few places that had training programs. So if you had that vision of going into anesthesia and critical care, really the only places you could train was at CHOP.
The dual-trained individuals that we trained in the 70s and early 80s went out, and many of them became the heads of pediatric anesthesia and critical care departments in other children's hospitals. So we trained, I think, as of now, well over 300 fellows. In fact, I think that was probably our major contribution to healthcare in this country, as far as our department was concerned, was the number of people that we trained who came through our program.
When you're a woman in medicine, there are two things you want. One is, of course, you want the resources. You want to, learn all the stuff. You want to be on the cutting edge of medicine. You want to do all those things that make a difference. You want the knowledge base, the research base, and everything else. But you also want to see women doing that work. You want to aspire to be like them. And that CHOP had. So whilst I was in training in Britain, I got a sense that this is what would fascinate me and keep me engaged with doing what I did. So I spoke to one of the surgeons there and asked where I would go to train. And he said, only one place, and that would be CHOP under Susan Nicholson.
I think that it's very important to recognize that at the end of whatever time that one trains, that you're not fully an expert in what area you seek to be, and that you have to continue that process with ongoing mentorship into whatever practice you join.
I can tell you that the first 6 months of my fellowship here at CHOP was more difficult than medical school. It was tough, and it's the kind of training where it's almost like boot camp. When you're in it, it's really, really difficult. When you're done with it, it's a huge accomplishment, but it was tough.
When someone commits to you as a faculty member 3 years of their lives to be prepared for a career, you have an obligation to train them properly.
That has been one of the most exciting aspects, is to see these bright, young, very dedicated people come through our program and learn from them. It has been an exciting part of my career, that's for sure. I got a lot of encouragement from one of our fellows, and he says, don't give up, don't give up. He said, we don't know where we're going, but don't give up. So we persisted. But then things began to improve a little bit. By 8 weeks of age, he was off the ventilator completely. So, long story short, he has grown up fine. But Michael was the sentinel case. He was the one that got us started. And if he had died or the outcome had been horrible, maybe our attitudes would have been quite different.
It really is a privilege to be with families. It's a very unique experience. Not many people get to be with a parent on the worst day of their life. And what we do on a day-to-day basis is try to take care of kids as if they were our own.
When parents bestow on you the responsibility of taking care of their critically ill child at the most tender moments in their lives and the most important moments in their lives, that's both an honor and an onerous responsibility. It's in the moment, you don't think about it, but in all moments you are aware of it.
What CHOP has done for Michael in saving his life is certainly worth doing, because he's grown up to be a good man, and he's giving to society. He's a good husband and father. He's a good family man. It takes a lot of energy and toil and work, and I know that the doctors sacrifice, and anyone in this field. It's not a field that you go into if you're selfish. It's a giving field, and I hope that They are rewarded with really having a sense of satisfaction when they see their little ones grow up into good adult people.
I got the best job in the world. Are you kidding? I got the best. I'm working at a wonderful institution with wonderful colleagues, incredible faculty, incredible nursing, and trainees. I mean, it's just, there are times I just pinch myself and say, this is unbelievable. This just can't be real.
The dedication is there. The deep and abiding concern, are we doing the best we can for this child? That's the essence of what makes this hospital a great place.
Well, to today's and tomorrow's doctors, I would just like to say in advance, thank you. And even though we can't ask you to help us because we're too small, I'd like to say, please help us and continue to help us the way your predecessors, like Dr. Downs, has helped myself, and keep fighting for those that don't have a voice.